So today we are bringing a missionary, a nurse, to this conversation, voice of hope. Nurses are without a doubt the backbone of any mobile clinic. They are on the front lines, dealing with the dynamic reality, the chaos of the triage, and the emotional weight of caring for patients in extreme situations like Mali and Senegal. It's a privilege to have Lillian Lima with us today to talk about this unfiltered reality. So, Lillian, you are very welcome.
Thank you so much. I'm very, very happy and honored to be speaking on this because it's such a big part of my life.
I know that. So, let's dig into it. Imagine this scenario: the mobile clinic, okay, during a missionary trip has just started the day, and you guys are flooded by hundreds of people. There is noise, there is dust, exhaustion already, and an overwhelming need. Let me ask this: how do you, on the front lines, make the decision of who should be seen first when resources and time are so limited?
I think that it's in the nursing field. When you're in school, they teach us a lot to prioritize patients on who's more important and who's more sick and who's more critical. In Africa, what we end up doing is we use the resources that we have. So we have paper and pen. So we give out numbers to everybody that comes in, and it's whoever gets there first. So we have a number of one, two, three, four, and then they end up lining up. Usually, when we are about to get started, we already have a crowd of patients already waiting for us because they hear a lot about, nurses, doctors coming from far, and they end up already lining up to already be seen by us. And you see that the necessity there is a really big. They're very needy there. They really need our care. So before we even start, there's already a crowd of people waiting for us in front of the clinic, and we give them a number, 1, 2, 3, 4, and then it's by order of who gets there first. But usually whenever a patient comes in and we see that they're having an active issue, like I've had a child before that she ended up coming in and she was actively having a seizure when she came in. So obviously she cuts in front of everybody. And there's also the cultural aspect where there's the people that are more important, I would say, in their culture. So like the men and maybe like the leader of the village. Usually they have more prioritization of care just because that's a cultural aspect and that's how they deal with their culture. So it's really by who's the sickest and who is more important in their culture.
That's a fantastic perspective. Let me think this. Uh, we know that in the ideal environment, the shift transition in a moment is a moment of risk in healthcare in the ideal environment. What I mean by that, the hospital, a clinic full of equipment and trained staff. But
Mhm.
in the midst of these calls, chaos, how do you pass the details of a critical patient, for example, to the next nurse? I mean, I'm talking about shifts, or you guys don't have shifts at all. Or how do
Mhm.
you transfer that patient to a local hospital, ensuring that vital information is not forgotten?
So working in the hospital, you get a lot of routine on how and education on how to properly give off shift report. That's what we call it. We give report on every patient that we get. We start off by giving something called an S bar format. So we give the situation of the patient, their background, assessment, and recommendation. For somebody that's in the United States, that's easy to do because here everybody knows their age, everybody knows their past medical history, everybody knows, what's going on with their life. So it's very easy transition to get here in the hospitals of the United States to give off a report to another patient or to another nurse about a patient. Since we follow that format, it's pretty easy on transferring a patient, but in Africa, it's a little bit more difficult just because patients end up coming to us and they don't even know their age. You ask them, "What's your name and what's your age?" Some of them don't know their age. I've had a 80-year-old woman tell me before that she was 20 years old, and you could tell that she was not 20 years old. But that's because in Africa, they're not educated enough to know their age. So it's really by assessment what we're assessing. As a nurse, usually I see them first and then they go to the doctor. And if the doctor sees that we don't have the right resources at our clinic, since we're a newer clinic, we end up transferring them to a local hospital. So we've had a patient before or a local clinic, we've had a patient before where the child, I think she was probably like 4 years old, if that, she was actively having a seizure. And we were trying to get her, back to reality. And we prayed over her and we rebuked if there was anything in the spiritual realm that was, making her have the seizure. We were rebuking it. And we were also trying to treat her with what we had there. But our treatment wasn't enough. She definitely needed to have some sort of neurologic following with a neurologist, and we didn't have that there. So we all got in the van, me and two doctors, and with the child and the mom of the child, and we went straight to the local clinic. When we got there, the clinic didn't have doctors. They said that the doctors were on vacation and there was only two nurses there the taking care of the patients. So then to make sure that we transitioned, we gave all the information that we could. We got there and the doctors were talking to the nurses, but we had a translator in the middle of it. So they gave off that report on what we assessed, what we know, and what the mom knew. And then we ended up even helping them out in the local clinic. So while we were there, the nurses already got the IV in the patient. They already started giving IV push medications. The doctor gave their recommendations, but it's a little bit harder in Africa trying to, you know, give off report on a patient, especially because of language barriers. So what they ended up doing is we have a translator and then we gave off our assessment and our recommendation based off what we see. Because like I said, it's so limited. Not everybody knows their history. It's kind of hard to give off adequate report, but we're there by the grace of God, the mercy of God. So I know that we're guided by the Holy Spirit, and also, thankfully, we're able to have our clinical knowledge from years of working in the hospital to know when something is wrong, what I should look for. So that's usually how we do it. Travou de novo. I don't know what's happening. Yeah. Mhm.
Então, com certeza, o problema dessa internet aqui do Leasing Office, que
Mhm.
tem esse problema. Então, você continua falando
Oh,
e e eu dou um refresh, eu entro de novo, tá?
okay.
Hum, então vamos. So, Lilia, and many volunteers suffer a major reality shock regarding hygienic conditions and extreme poverty. I know you have worked with Hope for Amical Food Foundation, at least in two different African countries.
Yeah.
But how do you balance the Western clinical protocol with this raw reality of the village, maintaining the patient's dignity while providing the necessary care?
This was definitely a really big reality shock for me. The first times that I went, all we had was gloves and hand sanitizer. And that's kind of not, what we're used to here in the United States at all. So that was a really big shock, especially since hygiene is such a big part of healthcare and taking care of your health. You need to be hygienic. You need to, take care of yourself. You need to shower. We don't really realize, but hygiene is a really big part of keeping a healthy life. And you can see how unhygienic they are. A lot of times they come with wounds that weren't treated for years, like their leg is about to get cut off, the wound is already up to their bone. You can see the openings of their skin, and it's all because they don't know how to take care of themselves and they don't know how to wash anything. They weren't ever taught. You can see that in their culture, you can see it in their country. So, I remember, like, a couple years ago when we went, I had a nurse from Mali helping me out, and since our resources are so limited, we would reuse, syringes, we on the same patient, we would reuse, needles on the same patient, and that is not something we do here in the United States, but that's their protocol there in Africa. So, if you were using one needle to, get blood and that needle or we didn't get the blood on the first try, you would reuse that same needle and keep going with that same needle back on the same patient. And in Africa, it's very, very hard because we don't have the resources. But at the same time, we're able to try our best to keep, the hygiene and keep a sterile environment. Um, Luckily, this past year that I went, I got my hospital donated some supplies to me. So we have these wipes where it wipes off any bacteria. So this past year, I was able to get to the clinic, and the clinic was absolutely disgusting. The clinic was falling apart. There was holes in the walls. It hasn't been used for years, and I ended up getting there, and I used the supplies that I got from my hospital to clean off any bacteria that we use in the and we got there. I started cleaning off the whole entire clinic bed. I started cleaning off, the doctor's tables. And one thing that I do every single year is whenever a patient comes to me with wounds, I do their wound care and I teach them, you're going to wash this every single day, 2 times a day. You're going to keep this dry. You're going to pray over your wound, and you're going to declare cure over your wound in the name of Jesus. And the patient is able to do that, and they start learning how to do something they never knew how to do before. Because to us, hygiene is really simple. We know that we need to take care of ourselves. We know we need to wash our hands. We know that we need to, take a shower. But in Africa, they don't know. They don't even have enough water to be taking care of themselves. So I tell the patients, all you have to do with this, with our limited resources, all you have to do is you're going to just wash them every day and pray over it. And then with that, after we come back in the next year, the same patient comes back and you can see how much the wound progressed and how much the wound got healed based off just hygiene. So we try our best. We, have our hand sanitizers. I bring some bleach wipes. I bring, whatever I can bring, and then there I can buy stuff for, like, wound care at the pharmacies, like sterile gauze and everything, but we just use what we have, we pray, and we teach them that the most important part about your health is your hygiene. So we teach them a lot about that on, take properly taking care of themselves. You see a lot of patients come in with UTIs, but that's because they also don't have hygiene, in the parts that they should be having hygiene. And they just don't know about it. They don't know that that's something that you're supposed to be doing. They live dirty, but that is their culture. But I know that us getting there and telling them, you need to take care of yourself with hygiene. You need to do this like at least 1 time a day. You need to Try to shower at least one time a day. You need to wash your hands every single time you go out. Stuff like that, you can see how much of a progression there already is in their healthcare just by having hygiene. So it was a really big reality shock, but I know that the Lord is giving us grace and He's guiding us on what to do with that aspect.
And how about this one? I know you start kind of answer that, but
Mhm.
in West Africa, like you often deal with these strong family hierarchies where the village leader or the eldest man in the family makes the health decisions for the patients. How do you as a nurse negotiate, the patient's treatment when you are r- running to these cultural barriers?
Yeah, so one thing that we learned very quickly is we have our culture here in the United States. In Brazil, they have their culture in Brazil, and Africa has their own culture. We can't change their culture. I know that in the first couple years, were trying to get into their country to help them out, but really trying to bring what we have and trying to kind of put it over them. But we quickly understood that that's not how things work in Africa. We know that we want, as Americans, people that are used to just helping out everybody, everybody has equal rights. Um, we want to get there and we want to help everybody and we want to provide our best care. But then when we get there, we realize that it's not like that. And unfortunately, we can't change everyone's culture. And we have to understand to respect their culture. So we've done a lot of things differently these past couple years. When we get there, usually there's a whole separate line for doctors for older men. The older men are seen just by one doctor, and then the women are seen just by another doctor. Sometimes we also have the leader of the village come by and he will already cut the line and he'll be the first one to be seen just because that's how their culture works. So there's no way around it. And to be well received in their country, they already mentioned to us that we need to respect their culture and we need to respect their religion. We need to respect, how they usually deal with things. We want everybody to have equal treatment. But since we can't have that in Africa, we try our best to explain to them the necessity of care. So if we see that one person in the family is having an issue with a certain health, a problem, and that is something that other people in the family needs to be treated for as well, um, we need to we need to have the woman come back with her husband and for the doctor to explain everything that is happening and clearly explain the treatment process, why it needs to be treated, and things like that. And then, depending on what the man says, usually they're after, explaining and respecting to call them, they're agreeable to treatment, but it's very hard. It's a very hard culture to deal with, but I know that we definitely make a difference because every single time that we are back there, they always come back looking for us and they're like, "Thank you so much for having introduced this to me. Like I really felt better after, I was treated for this and that." And that's kind of the reason why we always end up coming back. So, even though their culture is hard to deal with, we still respect them. We do as much as we can, even with our limitations, and they feel loved by us just respecting them and us being there for them. Every single time we come back there, they always say, "I've never felt loved like this," or "I've never felt so cared for like this." And it wasn't because we were trying to get there and impose anything, but it's because we were getting there and we were respecting their culture and respecting them and respecting, their needs and respecting their feelings on certain aspects of life and dealing with a lot of traumas. You see that unfortunately their culture, there's a lot of domestic violence in homes, or there's a lot of abuse with children where like children are being abused. And um when we start talking to the girls, and the girls usually are very intimidated at first by male doctors. They'll be very Like, they don't want any male doctor to see them because of any past trauma. But when we explain to them and when we take away the male doctors at first, we just talk to them, talk to them about treatment and stuff like that. Like, they're very open and they feel very seen because unfortunately it's not that unfortunately it's common in the African culture for this type of violence, and it's really really sad. But just us getting there and respecting their culture and seeing them as a soul that God loves, they definitely feel that love. They feel that maybe there's a God that's out there that really does love me, or I I really do feel seen. Maybe I am worth being cared for. So we respect their culture, but we bring in God's love, and not only that, we bring in care for them that they actually need. So it's very it's very hard, but we can I know we do it every year.
I love the way you balance your field and professional expertise with your faith when you
Mhm.
are answering the questions, because it's as we say in the interpretive medical field, it's a communicative autonomy, and you keep this relation with the patient as a human being, but
Mhm.
also as someone made. Um, Image of God. So God's image. So I love it this way. Uh, um, and how about language barrier, such am I say correctly? Bambara dialect in Mali is this the way
Umbada.
Bambara? Okay, Bambara. About the for example, the Bambara dialect so language barrier is a constant challenge.
Mhm.
Which medical instructions or medication names or dressing guidelines cause like the greatest risk of confusion when we are sending like the patients back to the village.
So the language is one of the hardest parts of working in Mali and in Senegal because not only do they not understand what we're saying, they don't understand healthcare. I've had many patients when I go to explain to them that they're going to take a pill for their blood pressure. I give them the pill, they start chewing the pill because they don't realize they're supposed to swallow it with water because they're not used to taking medicine. So, um in the clinics that we do there, always starts off with me. I usually get the basic things like their main complaint, their age, if they know their age, their name, their weight, their vital signs, and I always have a translator there with me. One of the nurses, we're fortunate enough to have like one of the local nurses with us all the time. But when the local nurse is not there, I have to just I learn certain things of their language. So I learn very, very basic questions like, what is your name? What is your age? What is your main complaint? Sometimes with their main complaint, it's a little bit hard, but you can kind of see a trend in what they all complain about. It's usually kind of the same things like gastritis, or they have like a migraine, or they have high blood pressure. So I kind of caught I started understanding a lot of things that they say, a lot of complaints, and I just write down a basic like summary of what they're feeling really quick to the doctor, because once they get to the doctor gets like a more in-depth um summary of what is going on, and there's like the translator there actively with them that can speak. I just get the basic things. So usually they say door the tits, so they'll point to their head. I'm like, oh, okay, you have a headache. Or like they'll say something when I see their blood pressure's high. I'm like, oh my gosh, yeah, you have high blood pressure. Um, and then initial triage is usually easy because I just get the basic vital signs and whatever their basic main complaint is. But afterwards, when I have to teach them what medications, and they also, a lot of them don't know how to read. So they have a um a way to understand when to take medications there. At the pharmacy, we built like a little pharmacy there, and before they leave, they stop at that pharmacy. On the medication box that they have, we write lines. And if it's like 2 lines, that means you take it 2 times a day. If it's 1 line, you take it 1 time a day. That's how they understand how to take pills. And to take it, you have to also teach them exactly how to take it. So you have to show them. Even us explaining things to them, they don't really understand. Even if it's in their language, they just don't have any, understanding of how to take care of themselves or healthcare. So we'll have like 1 line for the daytime, 2 lines for daytime and nighttime. If it's like 3 times a day, we'll like write a little slash and they understand it that way. And then we'll open the box, show them you're going to take this, you're going to put this liquid inside of here, you're going to take it like this. Or when I have to do wound care, I show them I do the wound care, but while I'm doing the wound care, I am showing them what to do, and I'm telling the translator to tell them, you're going to be doing this. So you want to wash this, you want to dry off this, make sure this part is dry before you wrap it. And they're it's hard for them to understand because they've never done that before, but they usually catch on and they do good. So it's like little tricks that we have to take to make them understand, but it works out.
So following up about this, for example, you have a patient's condition suddenly worsen during, the triage, for example, like mental confusion from malaria or severe dehydration. Which kind of f- trigger phrase or quick information can you just pass along to the doctors, to clear communicate without room for interpretation error that kind of situation it's just uh, erupting.
So luckily in at the clinics that we work at, sometimes we don't have, or most of the times we don't have anybody critical enough to end up, crashing while we're there. We say crashing, it's like if they have a rapid decline in their medical status. So if they start crashing, our communication needs to be short and quick to the point. So we just need to explain what happened. So they all of a sudden passed out. Their blood pressure all of a sudden dropped. They seem like they're very dehydrated. Their blood pressure shot up. It's kind of like a quick communication to fix that problem right in the moment. Um, it's also easier whenever we're in Africa to relay any information to the doctor because the doctor speaks our language. He speaks Portuguese, but the times that we have a doctor that's like from that local place, we usually just show up with the translator and indicate any signs on what happened. So rapid decline in blood pressure, altered mental status, severely dehydrated. We just get straight to the point, and that's how we do it here in the hospital too. Whenever there's like a rapid response or someone needs to have like urgently or needs to be urgently seen, we as soon as the medical team gets there, we get straight to the point. We're like, this and this happened. This is what was happening before, and we treat that condition on the spot instead of having a long relay on what happened.
Okay, let's transition a little bit for like a field improvisation and also technology. Which kind of technology you can use or workaround you can use, to uh, record part of the healthcare. Like which kind of workaround you use or trick you use to record and to have like a medical record for that patient? Is that possible?
So we don't we try our best with what we have. I think the best that we can do, we need to have a relay of how many patients we've seen by the end of the day. So that paper that we have initially, we have their number up at the top, their vital signs and their main complaint. When that exact paper gets to the doctor, he'll turn the paper around and he'll write down all the complaints and then he'll write down the prescription of the patient. After that prescription, they'll have a copy of that paper, and then they'll staple a copy of the prescriptions that they wrote on paper, and then they will have the papers every patient that we've seen. And at the end of the day, we count how many patients we've seen. So We don't have any electronic, electronic medical record, and a lot of the patients don't even have a medical record. They don't even have identification when we talk to them. They don't know, they don't have an ID with them. They have nothing. So we keep the papers on what we do just because we need to have we need to relay how many patients that we've seen and what medications um came out of the pharmacy. But we keep all those papers, and it's all papers that we just write down ourselves.
Wow. So, and I remembered from the Dr. Vinicius interview, he was talking about, image device, for example, will be very helpful in this mission trip. So, but like portable medical device like battery power vital signs monitor, glucometers, things like that, are they affected by the extreme heat or the dust, in under African sun?
So the heat, the dust, and the limited electricity really causes a big challenge for us. We definitely need to have, you know, vital signs machine. Dr. Vinicius said something that's very important. We don't have like any imaging, which would be very, very helpful, and we definitely need that. And our all of our prescriptions and everything that the doctor recommends is all off just an assessment. We don't really have lab work to go off of what they actually need just yet. I know that we're trying to work on all of that, but the technology part is hard. As a nurse, what I do, since I have all the equipment, I have to bring extra batteries. I have to like bring extra blood pressure monitor, extra glucometer. We have at least two or three of everything, because if anything were to happen that they stop working, I can't, there's not a pharmacy nearby for me to just run and go and grab something. I need to have everything already there. Now, if we don't have that, we use like basically what the patient is telling us. We use what we see and what we feel. So if the temperature monitor isn't working, I kind of just have to put my hand on the patient and see, do they have a fever, or is it just, are they high, or are they actually, is their blood pressure low? Like, I'm not sure. Or are they passing out? Like, what's going on? So we just have to use our clinical judgment when technology fails, which thankfully most of the time we're able to have everything that we need on like vitals machines and glucometer, the temperature probe. Since we always have extra, I always have extra batteries. I remember one time we ran out of we out of batteries, and the pastor Locatelli, he had to run out to the village and try to find somebody who had batteries to bring it back to the clinic. But in the meantime, we just, kept going with what we had. It definitely is a challenge, but we rely a lot of our on our physical assessments and teamwork, our clinical judgment to be able to keep the clinic going.
Great. My last question for you. From Pastor Fatima's interview, she mentioned that many volunteers have difficulties, right, processing everything they saw when they returned home. Dr. Vinicius mentioned that sometimes in the middle of care, he needs to stop, cry, compose himself, and then go back to see patients. How do you process? How do you process this emotional impact, not just during the shift, at the end of the shift, the day, but when you are back at home, how your face sustain your clinical practice in these kind of mission trips?
I definitely have a lot of moments that stay with me in Africa. Um, there you see a lot of things that to us is just so common, but to them it's not a reality. And sometimes we feel kind of guilty because we really can't do everything to help the patient. They need so much, but we can only give so little. And to deal with that, it's very something that Africa always teaches me every time I go is, even though they need so much, they have like a big need, they always seem to be so happy with what they have. And you don't ever see somebody coming in with, a big problem, but they're emotionally distressed. Usually they're just happy to be seen by a doctor. They're happy to be seen by the nurse. And when every patient gets there and we understand that everybody was created in God's image, we come to, create a love for them. And it is hard to see somebody in that situation, but in the very moment, I'm always so happy that they're happy to be seen. And then afterwards I take it home and I just have to pray about it. I just have to, understand that I can't save everybody, but I know that Jesus can. I know that if I didn't have God, or if I didn't realize that Jesus is the only savior, I think that I would feel a lot more guilty than normal on not being able to save everybody, not being able to help everybody. But I know that even though we gave as much as we could, at the end of the day, I know that Jesus goes way far beyond what we can ever give. And he's the one that can provide cure, can provide restoration, and provide love. So I give everything my all. I know that every single doctor there gives their all, and we really donate ourselves to be at their service. But at the end of the day, I know that Jesus is the only one that can really save them. Jesus is the only one that can be there for them. It is hard to deal with all of that, but at the same time, it's gratifying. Like, I'm here to help them, and I know that they're grateful to have me here.
Lillian, we have an upcoming trip to Senegal 2027. And I know everybody's getting excited in our, private groups, but for someone who's watching you right now, which words you have to them because they call it right now impacted by your interview and your feedback.
So the first time I went, I was 17 years old. And one thing I have to say to anybody that's thinking about going, don't wait until you feel ready to go, because it is a completely different environment, and you'll probably never feel ready because you're probably going to get there and you probably don't imagine what you're going to walk into. But God never calls those who are qualified. He always qualifies those that he calls. So if he called you to help out with missions, if it's going on this trip, if it's helping financially, if he called you to do that, he will give you the capacity and he will teach you on the way on how to, properly serve. As long as you have a humble heart and you are open to be volunteering and doing whatever you need, because when you get there, even if you're not a nurse, you turn into a nurse. Even if you're not a pharmacist, you turn into a pharmacist, because you're just there to help. You're just there to do whatever needs to be done. So I just say, don't ever let fear make you not want to go on these trips. If God called you and you feel that burning passion in your heart, like I know that God called me to go into missions, don't ever hold back, because we need volunteers. We need people that are willing to serve. And if you pray about it, if you prepare yourself spiritually, you are ready to be there and help out with missions, because we need people to represent Jesus, and we need people to bring more people to the kingdom of God. And we need more nurses. We need doctors. We need dentists. We need therapists. We need every type of care. If you are just a prayer warrior, please come. We need all the prayer that we can get. I am big in favor in telling everybody, if I could do it, they could do it. I started going for the first time when I was 17. And as a 17-year-old, you're just a child. And I still am a child. Yet I've been going for the past 6 years, and it's been the best 6 years of my life. So I really recommend anybody who has that burning passion in their heart to step up to what God calls them to do.
Lillian, thank you very much for thanks for your time, for sharing this very real experience. Feedback from the front line is extremely valuable for us to continue refining our infrastructure, our records,
Mm.
and our logistics. So this is how we make the Hope for a Miracle Foundation missions to Mali and Senegal safer, more agile, and above all, sustainable in the long term. Thanks very much.
Thank you.